Hi, this is Dr. Mark Poole, and I'm going to cover in this presentation non-neoplastic diseases of the stomach. This is content developed by myself and Drs. Giacatti, Mahan, and Lowe, so thank you to them. As I did with the esophagus, I'll start off reviewing a little normal stomach so that we have a firm baseline for comparing what's abnormal. So the stomach has five distinctive areas. The cardia is a small area, maybe 1 to 2 centimeters in length, emerging from the gastroesophageal junction, and is composed of mucous cells and gastric foveolar cells. The fundus is the next area, and this is where you start to encounter parietal cells, which are the main acid engine of the stomach, and chief cells, which produce the enzyme pepsin, which aids in the initial breakdown of gastric contents. The body is the largest portion of the stomach and also includes parietal cells and chief cells. The antrum is where mucous cells predominate in association with the gastric foveolar cells, and this is where there are also G cells, which are neuroendocrine type cells that produce the hormone gastrin. And then finally there's another short segment called the pylorus, which is a functional and physiological sphincter which controls gastric emptying into the duodenum. Microscopically, the entire stomach is lined by gastric foveolar mucinous cells. These form short pits, and then beneath these are the glandular component of the stomach. So on the left is where you have an admixture of bright eosinophilic cells, which are the parietal cells, and then paler lavender or faint pink cells, which are the chief cells. And again, these are found in the fundus and body of the stomach and are the chief workhorses of the stomach. Now on the right panel, this is the antrum, and the glandular component of the antrum is composed of these pale mucinous cells, and these secrete a less acidic mucin, which is serves to decrease the acidity of the gastric contents as it moves toward the duodenum. Of note, there are very few inflammatory cells in the lamina propria, and keep this in mind as we talk about the different inflammatory conditions in the stomach. So the first area that I'll talk about is gastropathy and acute gastritis. As you just saw, the normal lamina propria in the stomach has very few inflammatory cells. The presence of neutrophils in the lamina propria and in contact with the epithelium is abnormal anywhere in the GI tract. That's something to keep in mind as we go through other organs. Pathologists prefer the term active inflammation rather than acute inflammation for this phenomenon because it can occur in both acute and chronic gastritis. So you might come across the term chronic active gastritis or chronic active colitis, and that's what this means, is that the histology shows features of both chronic inflammation, that is the presence of lymphocytes or plasma cells or macrophages, and neutrophils. In gastropathy, the lamina propria may only show edema and vascular congestion in the capillaries, so it appears grossly or endoscopically as hyperemia, while the surface epithelium is intact and shows foveolar cell hyperplasia. In acute gastritis, neutrophils are present in the lamina propria as well as in the gastric epithelium, while lymphocytes and plasma cells are absent or not prominent at all. This is a figure from the Big Robbins as well as the Basic Pathology Robbins, which I think nicely illustrates the pathophysiological mechanisms of gastric injury. So on the left panel, it shows the normal defenses against the damaging forces of gastric acidity as well as peptic enzymes. And a key component of this is the mucus layer that's present on the surface of the epithelium. And you can see in the middle panel that injury occurs from a variety of different organisms and substances, both that are introduced to the stomach or from systemic causes. That's the lower arrow at the bottom of that image. And then finally, when there's complete damage of the mucosal thickness, we call that again ulcer. So remember, we learned about ulcers earlier in the general host defenses and responses, and now we're just applying it to the stomach as an organ. So this is what acute gastropathy or acute gastritis looks like grossly. You can still recognize the normal gastric rugae, but notice that the mucosal surface has a diffusely dark red hyperemic appearance. This is just a general appearance of acute gastropathy or acute gastritis and implies in no way what the specific underlying etiology is. Now, the presence of neutrophils is what allows us to distinguish microscopically acute gastritis, and the yellow circle highlights lobated inflammatory cells that are found invading into the gastric epithelium. And then if you note between the different epithelial glands, there's primarily neutrophils, although I must admit there are a sprinkling of plasma cells and lymphocytes as well. The key histological feature, however, is the predominance of neutrophils in this inflammatory infiltrate. Ulcers. You can have benign ulcers and malignant ulcers. Now we're going to put off malignant ulcers for the time being, and just I'm going to confine this presentation to benign non-neoplastic conditions. The most important cause of ulcers is peptic ulcer disease, which I'll talk a little bit later. But there are a number of stress-related ulcers which are also important. There are some non-stress-related ulcers I'm not going to talk about in detail. Stress-related mucosal disease, or so-called stress ulcers, occur with any critical illness or severe physiologic stress, severe trauma, extensive burns, intracranial disease, major surgery. There are some of these stress ulcers that carry some specific names, which are based on their location or clinical association. So you should be aware of curling ulcers. These are usually found in the proximal duodenum, but can occur in the stomach as well. And these are specifically associated with severe burns or trauma. There's also Cushing ulcers. These can be found anywhere in the esophagus, stomach, or duodenum. And these are specifically associated with intracranial disease. Of note, Cushing ulcers have a high incidence of perforation compared to other types of stress ulcers. This is the typical gross appearance of benign gastric ulcers. The blue circle includes several of these. Usually stress ulcers are located anywhere in the stomach and are most often multiple. These are sharply demarcated with adjacent normal mucosa. Microscopically, they have the typical appearance of an ulcer. Note again the sharp demarcation between normal mucosa and the base of the ulcer here. The ulcer has an underlying base of fibrosis and granulation tissue, above which is an inflammatory infiltrate consisting predominantly of neutrophils, and then the superficial aspect of the ulcer typically has fibrin, red blood cells, and inflammatory cells. This is just a higher microscopic view. to show you the superficial layer of acute inflammatory cells and fibrin, a band of acute inflammatory cells overlying granulation tissue, and fibrosis. All right, I'm going to turn to chronic gastritis now. The most common cause of chronic gastritis is due to infection by Helicobacter pylori, and this is responsible for about 90% of chronic gastritis. Autoimmune gastritis is the second most common type of chronic gastritis and accounts for 5 to 10% of cases. In contrast to acute gastritis, the symptoms in chronic gastritis are less severe but more persistent. Nausea and upper abdominal pain are most typical, but vomiting and hematemesis are uncommon. This is a unwanted poster of Helicobacter pylori. Helicobacter pylori are spiral-shaped with curved bacilli. They are present in gastric biopsy specimens from almost all patients with chronic gastritis or gastric ulcers. H. pylori infection most often presents as a chronic antral gastritis and is associated with usually normal or maybe even increased acid production. If this bug in the graphic looks familiar and reminds you of something from your childhood, perhaps this should ring a bell. Now you can tell these two organisms apart because one wants to rule your stomach while the other wants to rule the world. If only you had the secret Krabby Patty formula. Helicobacter pylori is uncommonly adapted to the harsh ecological environment of the stomach, particularly for survival in the gastric mucus layer. It has a number of different virulence tools to hack this environment, including urease, which generates ammonia from endogenous urea in ingested foods and produces ammonia, which then directly damages the epithelium as well as neutralizes acid, and this permits the survival of the organisms. Again, Helicobacter gastritis is more common in the antrum as opposed to the fundus. Histologically, it's identified by numerous plasma cells in the lamina propria. There's also frequent lymphocytes. Sometimes these form aggregates and even germinal centers, as pointed out by the red circle in the lower part of the image to the right. You can also see lymphocytes as well as neutrophils invading the epithelium. So in the panel on the right, the smaller red circle shows lymphocytes invading the epithelium. And then this is frequently an active or chronic active gastritis. So the panel in the lower left in the green circle shows numerous neutrophils invading the foveolar epithelium. And they're even forming a collection which we call microabscesses. Now you can identify Helicobacter pylori either in special histochemical stains, and this is an example of one in the upper left-hand corner which stains the organisms black or dark brown. And you can see that these organisms are identified in the superficial mucus. We can also use immunohistochemical stains to identify these organisms as well. There's also some laboratory tests that corroborate the infection. Usually gastric pH is normal, but it can either be slightly increased or slightly decreased. Gastrin levels are usually normal but can be markedly increased. And then there is a serological test for anti-Helicobacter antibodies, which is positive during and after infection. Why I'm spending a little more time on the chronic gastritis is because both chronic Helicobacter gastritis and autoimmune gastritis are associated with some important consequences. First and foremost is the association of Helicobacter gastritis with peptic ulcer disease. Nearly all peptic ulcers are associated with either Helicobacter pylori infection, the use of NSAIDs, that's NSAIDs, or cigarette smoking. It's also an important predisposing factor to the development of adenocarcinoma, as well as malignant non-Hodgkin's lymphoma. And we'll talk more about those in the neoplasia portion of the course down the road. But I'll talk a little bit more about peptic ulcer disease. Peptic ulcer disease refers to chronic mucosal ulceration affecting the duodenum or stomach. The involvement of the proximal duodenum is more common actually than the stomach for peptic ulcer disease. Nearly all peptic ulcers are caused by either Helicobacter pylori infections, the use of non-steroidal anti-inflammatory drugs, or cigarette smoking. There's a table in Robbins that shows a variety of other risk factors as well. In the stomach, the great majority of ulcers are solitary. This is in contrast to stress mucosal ulcers, which are usually multiple. Another contrast is that these ulcers in peptic ulcer disease are usually located along the lesser curvature at the junction of the body and the antrum. This is a couple endoscopic images of peptic ulcers. These are usually round to oval. They're sharply demarcated from the surrounding mucosa, which you might hear sometimes called a punched out type of defect, and they vary from superficial to deep. Now, grossly, you can't tell the difference between benign and malignant ulcers. You need histology in order to do that. But usually, shallow ulcers, like the one seen on the left panel, are typically benign, while those with heaped up or thickened edges and are deeper tend to be more malignant, like the one seen on the right. Histologically, however, peptic ulcer disease shows the same histologic features as those seen in stress ulcers, although the larger ones are associated with more evidence of them being chronic, that is, more degrees of fibrosis in the deep aspects of the ulcer. Autoimmune is the second most common cause of chronic gastritis. In this case, however, the chronic gastritis is composed predominantly of lymphocytes and macrophages. You can also see loss of mucin in the foveolar cells, and that's indicated in the middle panel by the blue circle. And then the other feature is atrophy of the specialized or mucus glands. So on the far right, I show two panels of the normal gastric mucosa in the fundus and body in the upper panel on the right, and mucus glands in the antrum in the lower panel, just for comparison with the red trapezoid in the left panel. And you can see that there's a marked dropout of the glandular component when you compare the panel on the left with the upper panel on the right. There's also intestinal metaplasia that goes along with the atrophy, and that's shown in the middle panel by the yellow arrows. Now, you might think, gee, this all looks a lot like Barrett esophagus in that there's gastric foveolar epithelium and intestinal mucus goblet cells or intestinal metaplasia, and you'd be exactly right. So you have to know where you're located and the background in order to tell such an image apart. Some of the ancillary laboratory tests that are associated with autoimmune gastritis contrast with those we see in Helicobacter gastritis. So in this case, gastric pH is decreased, and this is because of autoantibodies that are focused on the parietal cells in the stomach. Gastrin is markedly increased, and then you can also find anemia, so you check the hemoglobin, and sometimes vitamin B12 deficiency. Autoimmune gastritis also has some important consequences. As I just mentioned, anemia is one of them. When this is associated with vitamin B12 deficiency, this is called pernicious anemia. Now, vitamin B12 deficiency also has some multi-system effects, particularly involving the neurological system. Autoimmune gastritis is also associated with, it's not causing, but is associated with other autoimmune diseases. There's also a slight increased risk in adenocarcinoma, as well as in the development of multiple low-grade neuroendocrine tumors in the stomach, which you might see referred to as carcinoid tumors. All right, let me wrap up what you ought to have learned in this presentation. First of all, acute gastritis is caused by a variety of different noxious agents and stimuli. Fortunately, it all looks the same pathologically. We call it gastropathy when we see features of edema and vascular congestion but no neutrophils, and we call it acute gastritis when there are prominent neutrophils. Gastric ulcers may be acute. Most of these are stress-related. There are some non-stress-related causes as well. Peptic ulcer disease is the major cause of ulcers, and usually this is associated with Helicobacter gastritis, but also other things as well. And then finally, you learned about chronic gastritis. About 90% of chronic gastritis is caused by Helicobacter pylori, and the other 5 to 10% are caused by autoimmune gastritis. There are some other uncommon causes of chronic gastritis which I didn't talk about and you don't need to worry about. The important thing is that both of these are associated with an increased risk of malignancy as well as other diseases as well. So that ends up the non-neoplastic diseases of the stomach. Good luck. Thank you.